and apologies for the delay in the start. We encountered some tech problems, but I think we're good to go now. So we've got 50 minutes for the session. The session is a symposium, and the title is Working Towards a Healthy Africa, Evidence for Strengthening Vaccination Programs. So my name is Dr. Sibanda. I'm the scientific advisor at the South African Vaccination and Immunization Center. We're going to be joined online by two guests, Professor Andy Stergachis, who is a professor of pharmacy and global health, and he's also an adjunct professor of health metrics, sciences, and epidemiology. He's an expert in immunization, and his talk today will be on maternal immunization safety surveillance and resources for vaccines targeting pathogens with pandemic potential. Just after him, we'll be joined by Professor Hanelie Meyer, who is the head of the South African Vaccination Immunization Center, based at SMU, Sefako Mahato Health Sciences University in South Africa. So Professor Meyer is a professor in the Department of Public Health Pharmacy and Management within the School of Pharmacy at SMU. And then physically here we're joined by Dr. Raberra Kenyanya, who is a specialist pharmacist with over 13 years of experience in various clinical, administrative, policy and leadership positions in the public health service delivery. She's going to talk to us about pandemic preparedness of African vaccine manufacturers. It's going to be a very exciting session. And this is really informed by the importance of vaccines. Vaccines are one of the greatest advances in history, in medical history. And annually, vaccines are estimated to save about 4 million lives. And there's been the implementation of the Immunization Agenda 2030 that really speaks to strengthening vaccine access, including life course immunization, including strengthening of vaccine capacity by way of strengthening vaccine manufacturing in Africa and throughout the world. So without wasting too much time, I'm going to ask Dr. Andy to come through and share his presentation. I'm going to stop sharing this side and ask you, Andy, to please share your presentation.
Okay.
And then over to you.
Thank you very much. Give me 1 second to make sure my screen is showing. Are you able to see my first slide in presentation mode?
Yes, we can see.
Okay, wonderful. Good evening, everybody. Again, I'm Andy Stergachis. I'm based in Seattle, Washington. I'm going to touch on two related topics, focusing on special population of keen interest. Pregnant people bearing age are commonly excluded from clinical trials unless they have a reliable form of birth control. Consequently, we end up with no or very limited information on the safety of medicines, drugs, and vaccines during pregnancy, which results in a fair amount of concern about the fact that we do not have sufficient information about policies or even clinical care for women in childbearing age. Additionally, we're seeing increasingly the introduction of new vaccines and drugs for maternal and neonatal health being introduced directly into low and middle income countries, which means that it's really important to have the capacity and the will to continue to follow the safety of these in order to strengthen vaccination programs. One approach to this is the use of pregnancy exposure registries and similar systems to monitor post-introduction product safety. So what is a pregnancy exposure registry? Essentially, it's active monitoring in order to be able to estimate incidence, risk factors, and relative risk. These are established in a coordinated manner to follow women who've had exposure to vaccines of interest early in pregnancy or sometime during pregnancy before the outcome is known, and then systematically recording the outcomes, not only of the pregnancy, but also infant outcomes as well. This photo here is actually from an ongoing pregnancy registry in West Africa, as well as in Burkina Faso, called the MIMBA Pregnancy Registry. Now, the essence of how to do this kind of work essentially requires information on three components. One is the exposure itself, that is the vaccines, and then the outcomes themselves of the pregnant woman as well as the child or the infant, and then information about the pertinent medical history, concomitant medications, and other relevant variables. I'm calling attention to this open source textbook on maternal immunization that also includes a chapter that my collaborator, Dr. Sabine, and I developed on safety surveillance systems for maternal and neonatal safety. So just a few months ago, the World Health Organization posted on their website a landscape assessment of where are these pregnancy exposure registries, as well as related resources for estimation of the safety of vaccines and other medical products during pregnancy. We participated in that along with PATH and identified some 45 different resources that are out there in low and middle income countries, and of those 36 are presently active. And you can see here some of them are things like health and demographic surveillance systems, as well as registries that are overseen by manufacturers. Now, the question you might ask is, how important is this information? Well, this illustrates just how important it was for understanding the safety of COVID-19 vaccines used during pregnancy, because there were no trials. All the information we were able to collect came from observational studies, such as cohort studies and pregnancy exposure registries. And this was amassed over 500,000 well-defined exposures and outcomes associated with them from studies across the world of some 41 countries. And the reassurance from this work, a living systematic review, was that we found no concerning safety issues as they relate to the use of COVID-19 vaccines during pregnancy. You see down below on this slide that this living systematic review is now being expanded to vaccines for other priority pathogens, such as Lassa fever, chikungunya, and what might be around the corner, which is referred to as disease X. Now I want to switch attention just for a few minutes to vaccines in development for issues, that is viruses and pathogens that have the pandemic potential, or at least the potential for epidemics. And there is an organization called CEPI, which is the Coalition for Pandemic Preparedness Innovation, that is focusing on the identification of and support of vaccine development that could be available within 100 days of recognition of a pandemic pathogen. And you can see here that the development cycle was able to be reduced to about a year for the COVID-19 vaccines, but there's a lot of concerted effort to compress those timelines for priority pathogens by the World Health Organization, such as Lassa, Nipah, Rift Valley fever, and others. What will it take? Well, it will take a lot of effort, including the establishment of research networks throughout areas where these pathogens are presently in circulation in some manner or another, as well as integrated pharmacovigilance and risk management processes into the global manufacture of vaccines. One of the efforts supported by CEPI that we're involved in here is the Safety Platform for Emergency Vaccines, which has a whole series of work packages, including supporting the development of case definitions and supportive information for adverse events of special interest, vaccine safety templates, focusing on special populations such as pregnant women, children, and immunocompromised individuals, as well as planning for the need for safety surveillance beyond routine passive surveillance. And that's the focus of one of the work packages that I co-directed with Dr. Sabine. This is just an example of one of the many resources of SPEAK. And this is a whole series of identified potential adverse events of special interest, either related to the virus and the condition or infection, or related to the possibility of the platform or the antigen itself. And for each and every one of these, there's an effort underway to develop case definitions that can be used for surveillance purposes, pharmacovigilance purposes, as well as companion guides that have a wealth of information about MEDRA codes and background rates. This summarizes for you in a convenient way the resources that I've walked through very, very quickly that might be helpful to you as you plan for risk management and pharmacovigilance, not only for vaccines used during pregnancy, but also for vaccines for novel vaccines for conditions that might develop into pandemics or epidemics. I'll leave you with these key points. It's really important to strengthen and adapt existing safety surveillance platforms for introduction of new maternal vaccines and therapeutics. It's also important because some of these adverse events of special interest might be rare, to look for ways of harmonizing the processes and allowing for data pooling for meta-analyses such as systematic reviews. Digital solutions for data collection are terribly important, extremely important, to allow for efficient data capture and even records linkage for retrospective analyses. The importance of strengthening the collaborations between EPI programs and pharmacovigilance programs is essential, and regional and country ownership, I think, is key to sustained adoption and implementation of these strategies for surveillance of safety of vaccines when used during pregnancy, as well as for novel vaccines under development for priority pathogens. Thank you very much, and I'll turn it now to Dr. Hanelie and stop sharing my slides.
Thanks, Andy, for that informative presentation. I know you've been up since 4 a.m. your time. It's around 5:30 a.m. in Seattle at the moment. We appreciate your commitment to joining us. Please stay on a little bit longer for the Q&A at the end of the session. Now we're going to hear from Professor Hanelie Meyer, who is going to address one of the strategies of the IA 2030 Immunization Agenda 2030, which is to increase vaccine acceptance, build vaccine confidence, as well as reduce vaccine hesitancy. Over to you, Professor Meyer.
Thank you. Can I just check whether you can see my full screen?
Yes,
my full slides?
We can.
In presentation mode?
We can.
Okay, I don't know if I should show my video, but just to wave to everybody, whoever is there. Thank you very much for the opportunity to talk about building vaccine confidence, which is very, very important. So I'll stop sharing my video. I have no conflicts of interest to declare for this meeting, and I would like to start with these no-brainer questions about vaccines. So as healthcare professionals, as researchers and academics, how often do we get these questions? evidence that accumulated over so many years of the benefits of vaccines, their effectiveness, their safety, and saving millions and millions of lives each and every year. So although the COVID-19 pandemic increased public awareness of the importance of vaccines, it has also fueled vaccine hesitancy and resulted in a decrease in confidence in vaccines in general. So this UNICEF report was published last year, and it shows that people's confidence that vaccines are important for children dropped significantly after the start of the pandemic. So if I can use South Africa and Ghana as examples, as you can see, they are far down the list, with only 60 to 62% of the population considering childhood vaccines as important, showing a decline in confidence of at least about 30%. Now, this paper was published earlier this year, and it was based on surveys conducted in 23 countries, looking at immunization and health information and also pandemic preparedness. So this paper also shows evidence of vaccine hesitancy towards other vaccines and challenges with trust in health information, highlighting the need for targeted, culturally sensitive communication strategies. Now, from this paper, this graph shows people's willingness to get vaccinated against other diseases such as influenza, measles, and hepatitis B. And we know that we are seeing outbreaks of, for example, measles and other vaccine-preventable diseases. Although the responses differ by country, overall, almost a quarter of respondents were unsure or unwilling to get vaccinated. Now, in terms of pandemic preparedness, here you can see people's willingness to get vaccinated should the World Health Organization tomorrow announce a new pandemic. And overall, a third of respondents were actually unsure or unwilling to get vaccinated. Now, let's quickly revisit the definition of vaccine hesitancy, which is known as a delay in acceptance or refusal of vaccines despite the fact that vaccination services are being available. So vaccine hesitancy is a very, very complex phenomenon, and it is vaccine specific, it's context specific, with variation in terms of time and population. So in one simple word, vaccine hesitancy is known as indecision. So it's the inability to make a decision whether to accept a vaccine or to refuse a vaccine. Now, research suggests that there are 5 main drivers of vaccine hesitancy, known as the 5 C's or the 5C model, which I will refer to later in the presentation as well. So confidence refers to the trust in the effectiveness and safety of the vaccines, the system that delivers them, and the people making the decisions about the vaccines. Complacency exists where perceived risks of vaccine-preventable diseases are low, and vaccination is not deemed a necessary preventative action any longer. Convenience or constraints refer to the structural barriers, for people to access vaccines. Calculation is about seeking information and weighing the benefits and the risks when making a decision about vaccination. And the last one, collective responsibility, is about understanding the value of vaccination for creating herd immunity. Sorry, my mouse is very sensitive. So it is important for us to understand the drivers of vaccine uptake to be able to design appropriate interventions. So I'd like to encourage you to look at this guide, which is recommended also by the WHO SAGE group. And the tools in this guide can be used to measure behavioral and social drivers of vaccination. And it can assist you with collecting data systematically so that you can track trends of uptake of vaccination and monitor and also evaluate interventions. Now, there's been a lot of work done, especially during the COVID-19 pandemic, in terms of designing interventions. and building confidence in vaccines. And many reviews have been published as well. So I will just highlight two of them. So the first one is, what is the best communication interventions to counter misinformation and change attitudes and behavior? So based on this review, what I want to highlight is the importance of tailoring public health messages for groups with low uptake, and then to monitor the actual uptake of vaccines. And then another important limitation highlighted by this review is the impact of interventions on actual uptake was not measured. So this points to the need for future research, as well as the importance of having electronic vaccination records, because that will be the only way in which we can actually monitor real uptake and determine the impact of these interventions. And then I just want to point to the potentially unhelpful strategies that we need to guard against, is by using scare tactics and not acknowledging people's uncertainty about vaccines. But you can go and read more on this on these issues from this paper. So another one is about community interventions. Very important is to use the right approach for the right group. So in other words, our interventions need to be very context specific. So just to highlight, we need to understand the community needs, the different cultures. We need to build trust, use community advocates, avoid missed opportunities by bringing the vaccination conversation into each and every healthcare visit. Educate children, especially when it comes to HPV vaccines, and lastly, but very importantly, make vaccines accessible in the communities and places which are most accessible to them and most convenient to them. Now, it is important to have a validated tool to be able to predict vaccination behavior, but also to measure the impact of interventions. So this 5C scale was developed by Cornelia Betsch and her colleagues based on the 5C model, which I explained earlier on. But this scale was developed and validated in high-income countries. So it has a short version of 5 items and a long version of 15 items. And respondents would then indicate their agreement or disagreement with these statements on a 7-point Likert scale, which is then scored for purposes of analysis. And then these items are then being used within the 5 determinants or constructs or antecedents, as they refer to them, to then predict vaccination behavior. So now the question is, can we use this scale in our settings, in a low and middle income country setting, or any other setting, across the world where it hasn't been validated yet? So we tested the short version of the 5C scale in South Africa to determine whether we will be able to use this to predict HPV vaccination behavior. And we used a paper-based survey amongst caregivers of age-eligible girls for HPV vaccination in public sector schools. And then we compared the mean scores of caregivers with vaccinated girls to those with unvaccinated girls. And we found from this research, as you can see here, that the confidence and collective responsibility constructs were good predictors of positive vaccination behavior. Complacency and constraints were good predictors of negative vaccination behavior, but calculation was the complicated one, and it was not predictive. So it shows that we need to rephrase the calculation statement for measuring calculation within the South African context specifically. So we then went ahead, and it was then during the COVID-19 pandemic, we investigated this further among South African school educators. And this time we used the long version of the 5C scale. We adapted it for the South African context, and we also added an additional item. Then because of the pandemic, we used an electronic survey on the SurveyMonkey platform. So here you can see the results of this survey. Once again, we compared the mean scores of the vaccinated educators with the unvaccinated in terms of COVID-19. And what we found, again, so I've just put the 5C scale there for you as a reminder. We again found confidence and collective responsibility being good predictors of positive vaccination behavior. Complacency, a good predictor of negative vaccination behavior. But then within the constraints construct, 3 of the items were good predictors, while one item was not a good predictor. And calculation, again, now using 3 items or 3 statements, again, not a good predictor within this population and within the South African context. So we then went further and we then tested this 16 scale item amongst pharmacy personnel in South Africa, once again using an electronic survey. And this time we looked at the vaccination uptake as well as advice given by pharmacy personnel. And we found a significant association between vaccinated against COVID-19 and advising others to receive the vaccine. And then in terms of the items within the scale, for pharmacy personnel it was very interesting because confidence and collective responsibility were good predictors of both vaccination practices as well as willingness to advise others. And we know that pharmacists and pharmacy personnel are very prominent within the community, playing a very important role because they are accessible to patients and they are also trusted healthcare professionals. Complacency and constraints and calculation were good predictors of unwillingness to advise others, and complacency and constraints and calculation good predictors of negative vaccination practices, except for one of the constraints construct. So the scale worked, except for the one item, worked quite well within this particular group, pointing once again that you need to adapt and select certain items for certain populations, highlighting the issue of vaccine hesitancy being a very context-specific phenomenon. So in conclusion, we know there's a decline in vaccine confidence following the COVID-19 pandemic, and this is a threat to vaccine uptake in general. It's important to understand the drivers of vaccine hesitancy to be able to target interventions and determine behavior. We need interventions appropriate for the context, so we need to use the right approach for the right group. We need to use validated tools to predict vaccination behavior and measure the impact of interventions, together with making sure we can actually move towards electronic vaccination records. And then lastly, there's a lot of research still needed to measure the impact of actual vaccine uptake and to be able to use validated measurement tools. So thank you very much for your attention and acknowledgements to all my STAVIC colleagues in South Africa as we are working towards an African continent free of vaccine preventable diseases. Thank you. I'm now handing over to Dr. Raberra.
Right, thank you very much, Professor Meyer. That was an exciting talk. I specifically liked the point that you raised, that we need to understand the drivers of vaccine hesitancy in order to come up with the right interventions. So I'm going to call upon now Dr. Raberra, who is going to speak to us from the perspective of a vaccine manufacturer. Her topic will be on pandemic preparedness of vaccine manufacturers.
This is something that most of the people in this room are far too interested to know about what we are doing as Kenya when it comes to vaccine manufacturing. But allow me to take you through an overview of what exactly African manufacturers are going through in terms of pandemic preparedness. And thereafter, I will give you another overview on how exactly now Kenya specifically is getting ready for disease X, as was indicated by Professor Andy earlier. So there's this one quote that keeps on ringing in my mind every single time I make a presentation. I know that we know about the impact of vaccination, but appreciating what it means to us who grew up in an era where we were able to access primary immunization against the people who did not get it, which was about 1 or 2 generations before that, is something that we have to come to grips with every single moment we hear the word vaccines or vaccination. And Plotkin and Mortimer indicated that the impact of vaccination on the health of the world's peoples is hard to exaggerate. With the exception of safe water, no other modality has had such a major effect on mortality reduction and population growth. So in that same spirit, what happened was that the Global Vaccine Action Plan that is being spearheaded by the World Health Organization looked at some certain pillars upon which we could be able to maintain and sustain vaccination programs across the world. And they did talk about some certain pillars that we are all aware of, things around innovation, sustainability, integration, equity, shared responsibility, and partnership. And then there was also the matter about country ownership. We are fully aware that what ended up happening in 2020 made that really last point something that became a very present truth for most African countries, from the standpoint that most African countries were not in a position to actually protect the lives of their people. So there have been multiple discussions on this particular matter, on how exactly we can be able to prioritize as a continent and as nations on optimal immunization delivery. So there's some certain pillars that have been talked about from a policy standpoint, and I'm pretty sure the people in this room can appreciate it. From a standpoint of making sure that we have zero-dose children, making sure that there is collaboration amongst multiple partners, that's government, non-governmental, and private sector, making sure that we have strengthened our primary healthcare systems, making sure that we have sustainable financing, both from the government and from the collaborators who are supporting this particular initiative. And lastly, and that's why we're having this particular discussion, strengthening matters around local manufacturing. So I know that the previous presenters and even other speakers during this conference have spoken to what exactly we went through in the COVID-19 pandemic that has catalyzed some few movements and shifts in this particular perspective. But we actually import more than 98% of our vaccine requirements as a continent. And as Kenya, it's 100%, meaning that if the borders were to be closed right now, we would be no way safe in the event that we have any crisis. Case in point, what happened a month ago with the primary immunization program's vaccines. And as was indicated today morning, we import over 75% of our pharmaceutical needs. And there is a need, now more than ever, to establish and increase local vaccine production capabilities, not just for Kenya, but even for the region. And most of the countries have been affected or are going to be affected within the next 10 years by the accelerated transition from Gavi support. If you're fully aware of the fact that our primary immunization program has been co-financed by Gavi since the 90s. And right now, Kenya is in a phase where after our reclassification into a lower middle income country, we are in the accelerated phase that by 2029 December, we should be in a position to either buy all of the vaccines, basically finance our primary immunization program by 100%, or we should be in a position to manufacture some of the vaccines that we utilize so that we can be able to maintain that particular program. And we're not the only ones. We are 45 countries in the continent who are receiving this particular support. Within the region, there are other countries that are going to be they're going to transit by 2040. So what does that mean to us and the region if we are not able to either get the money to sustain the primary immunization programs or get the money to set up manufacturing capabilities to ensure that we can be able to secure the health of our people? So there is this active thought process around making sure that African manufacturers are able to undertake a framework for action. This is by the PAVM, Partnerships for Africa Vaccine Manufacturers, which is a secretariat under the Africa CDC. And they came up with an 8-pillar program that African manufacturers are required to take up actively to ensure that they can be in a position to prepare adequately and learn from lessons from other countries that have undertaken vaccine manufacturing before. As it stands right now, the continent and most other continents are reliant on one manufacturer located in Pune, that's Serum Institute of India, who manufactures over 90% of the global vaccine requirements. So if anything were to happen to that particular manufacturer, it means that South America, Asia, Africa, and some parts of the Western world will be affected because of that particular matter. So it ties up to multiple areas, the first one being market design. There was that conversation in the morning. But understanding fully, based off of Professor Meyer's presentation, will people actually trust what it is that we're actually giving them? Or will the African governments actually want to buy the products that we are going to be able to give them? And even if they're going to buy, will we be able to give them an attractive price point against what it is that, let's say, Serum Institute or Bharat Institute are able to give? And noting that they are leveraging on economies of scale, and whatever the African manufacturers will be manufacturing against, case in point, right now the finance bill is being read out, the budget for the next financial year and the finance implications, the taxations that are being leveraged on African manufacturers and whatever incentives that they can possibly get so that they can be able to price match the ones that are coming in from outside of the continent. Then access to finance. I appreciate that there may be some manufacturers in the room right now, and access to finance is one of the biggest hindrances to even ensure that you can meet basic GMP requirements. And this is something that begins to be quite difficult, especially in vaccine manufacturing, where you need between 50 to 70 billion US dollars to set up a mid-sized vaccine manufacturing plant. And that is just set up for the first 5 years. Subsequent to that, your operational costs will be about 20 billion US dollars. Then thereafter, there is a matter about regulatory strengthening. The conversation about ML3, it's predicated on the fact that we also need to be able to get there to be able to manufacture vaccines. If the regulator cannot get to maturity level 3, then we will not be in a position to manufacture vaccines in the country, or even if we start manufacturing it within the country, we would have to send our samples to another country for validation before we can be able to undertake lot release within the country. Then there is the matter around technology transfer and IP. I appreciate the presence of some of our lecturers in the room, and they fully understand that this is a process that takes time, requires expertise, and is quite costly. And it is one of the areas that is fairly not as well taught in our undergraduate for us to appreciate the nuances around intellectual property and how another manufacturer who owns the intellectual property can be able to own the rest of your production line for the entirety of your production, which can be over 50 years. So it's the thought process around how exactly we can get into some very concise and profitable intellectual property contracts with the established manufacturers to ensure that the technology that we transfer for our production does not cause us to get into bad debt at the end of the day. Then appreciating research and development and talent development. The conversation around the chicken and egg. Do our schools upskill, or do our researchers train the people who are in the schools to make sure that we can get fit for purpose people? And Kenya is actually quite lucky because we have some established research institutions that are actually within this space, which makes it very easy for us to be able to take out this particular talent pool and use them when there is need for it. And lastly, infrastructure development. For context, there's the matter around how the continent is going to work within the trade areas of AFCTA and also setting up the structures themselves. However, these are still at conversation phase. What we have been able to put in place has not necessarily touched on health products. It's touched on other non-health products, but there's a push towards that for Africa vaccine manufacturers. I'll just give you a very brief overview of what Kenya is currently doing. So the government of Kenya itself established the Kenya Biovax Institute in September 2021, and we are set up to manufacture, commercialize, and undertake research and development for specialized HPTs, including human vaccines. And I will not go through the entire slide, but I'll just indicate that the whole essence of its existence is to make sure that Kenya gets to a level of self-sustenance and self-reliance, to the point where we will be in a position to make sure that we have secured the safety of our people and the people around us. And the rationale for that still ties into what I'd said earlier about the Global Vaccine Action Plan, and also what Africa's prioritization is, which is we need to be prepared to be able to make sure that we have resilience of supply chains against any health emergencies. We've talked about disease X. We do not know when it will hit, but we know it is coming sooner rather than later. In addition to that, we need to be able to contribute to universal health coverage and strengthen our local manufacturing sector, and also leverage on existing skills and potential know-how. As a country, we are lucky to have our head of state as the AU champion on manufacturing of vaccines and diagnostics. However, what does that mean for Kenya and the region? It's a matter around how exactly we can be able to leverage on matters around the ecosystem to strengthen the manufacturers in readiness for our eventual preparedness role. In addition to that, it also means that we have to work closely with our researchers in the public health institutes, who are constantly undertaking surveillance, so that we can be able to know when a disease outbreak is happening, when there's a potential epidemic and a potential pandemic, because of the levels in which these particular matters exist. What does that mean? It means that everyone in this room has a role to play, within this room and outside of this room. We need academia on board. We need our quality assurance and quality control systems on board, our regulatory system on board. In addition to that, we need to be able to coordinate supply chain and market access. And further to that, we need to be able to make sure that the consumers, even you yourselves, are confident in the products that the African manufacturer will be able to make. In the event that you, as the professional, cannot be able to convince yourself of the quality, then what will that mean for your grandmother who is in the village and she's been left with the child to bring to the clinic to get a vaccine made by Kenya Biovax? I'll stop at that.
Thank you very much, Dr. Raberra. That's an exciting presentation and very enlightening. We definitely need to strengthen our capacity in terms of vaccine manufacturing. I've been asked to really limit our Q&A, so I'm going to open it up to maybe 2 or 3 very hot questions. Does anyone want to ask something? Yes, I see a couple of hands.
Good afternoon. My name is Shahada. I work at KILIFI County Hospital. So my question would be, I first have to say I'm quite passionate about antimicrobial stewardship, and one of the things that you talk about in antimicrobial stewardship is reduction of deaths by antimicrobial resistance, and this will be by preventing infection, and we will prevent infection by vaccination essentially. But recently we've seen the stockouts of vaccines at the public facilities, and most children have been affected, and we've seen a very huge number of children who have missed this vaccine because of vaccination. And so my question would be, how ready are we that by that 2030, as Gavi transition, we will be able to fully finance the vaccination program? Because already we are not yet at 100% financing as a country, but then we are already feeling the effect of this transition already.
Okay,
yeah.
Thank you very much. Another question? All right, Dr. Raberra, you can quickly answer that while we wait for the second question.
Thank you. Sorry, please remind me your name? Mary.
Mary Shahada.
Shahada?
Yes.
Okay. Dr. Shahada, you have asked a question that would ideally be directed to the Principal Secretary, but I'll try my best. So you're talking about healthcare financing at the end of the day, sustainable financing for maintenance of the primary immunization program. How ready are we? I'll take it as a two-parter from the manufacturing perspective and how ready we will be by 2029 December, and then also from a financing perspective on how ready we will be. And I wish I would have the opportunity to invite a colleague of mine who we worked with very closely at the UHC Secretariat, but I'll take the question for now, Dr. Nyakiba. So on this particular matter, it's a very sensitive matter around budgetary allocations. So we always think about budgetary allocations as an arbitrary matter that happens at Parliament and has no direct impact. But from an AMS perspective and AMR in general and what Kenya is actually grappling with right now, there's an appreciation that without the directed financing, or rather without the directed allocation and subsequent financing, because those are two different things, it gets really difficult to be able to actually offset our goals. So for all intents and purposes, the plans in terms of allocation on paper are there. However, now, depending on how our economic strength or lack thereof will be, that will impact whether or not we'll be able to pay up on this other side. So I really can't answer that with a concrete answer. It's a matter of, are we advocating from a professional standpoint on allocations during the budgetary process to make sure that the primary immunization program gets the financing it requires. Then now, on this other side, from a manufacturing perspective, I would say that it is a matter of we are working towards it so that we would ensure that by the time we are hitting 2029 December, we would have at least three products in the pipeline. Our schedule has 14. So while we are working towards putting up the three, setting up vaccine manufacturing takes between 5 to 7 years. A proper vaccine manufacturing plant, and on this other side, we also have to work in tandem with the regulator as they upgrade their systems to be able to actually regulate vaccine manufacturing. So it's not that the regulator is ready, the regulator is also working with us to get there. So that's why we're giving ourselves that timeline to make sure that we can be able to get there. On this other side, we will work closely with now the relevant manufacturers to ensure that we can be able to maintain the 14 schedule antigens to make sure that we do not have a stock out as a company. Thanks.
All right, thank you very much. To Professor Hanelie Meyer, I just want to ask how important is religion and culture as a factor counting for or against vaccine uptake? And where does it fall in the 5C scales?
Yes, thank you for that question. It's been shown, like I mentioned, the 5C scale was developed and validated in 9 countries. And that is actually one of the items that we added to, especially the latest 2 surveys that I haven't shown results on. So there's an item on personal beliefs as well as an item on religion. And both of them were identified as predictors of vaccination behavior. So it's very important. There's also some other results that's also not been published yet from South Africa. We've just received the results, and religion again has popped up as a very important factor in vaccination. So definitely it just illustrates again the importance of always considering the context within which you are working. So yes, for our context, and I'm sure throughout Africa we will see exactly the same in terms of religion. Thank you.
If I can add, this is Stergachis. In the U.S., there has been research that has shown that even a political party has an effect on vaccine uptake, in a manner in which we're quite polarized here, and areas of the country where there's a predominance, for example, of Republican right wing, if you will, there's lower immunization rates. So that's, I just want to add one more factor that regrettably we've been experiencing here in the U.S. Over.
All right.
Yes, we've actually experienced the same in South Africa right at the start of the pandemic, even before the vaccines were rolled out. One of the prominent parties, there were some politicians making certain statements, and that has had a really a negative impact on the overall confidence when the vaccines were eventually rolled out. Yeah, unfortunately, the politics will be following us.
All right, thank you. Prof. Andy, one last question. In terms of the systems for immunization surveillance amongst pregnant women and neonates, does the US have an integrated system with, say, the normal pharmacovigilance of, ethical medicines, regular medicines, or is this a standalone system? And how would we go about implementing a similar system in Africa?
Yeah, thank you for the question. The best way to characterize the U.S. system is its systems. That is more than one. For identification of possible safety signals, we rely on something called DARES, which is reporting on the part of astute clinicians and patients into the U.S. FDA or the Centers for Disease Control. But we also have systems for active monitoring. And there's a couple of ways this is done here. We rely quite a bit on the use of databases that are based on either electronic health records or insurance claims that have been reimbursed. And these large linkable data systems have been extremely useful for understanding the extent to which these vaccines, as well as other medications, are. We also have stood up active safety surveillance approaches in relation with, for example, with the COVID-19 vaccine. There was an app called Be Safe, that people who receive the vaccine can sign up and then report in on a periodic basis their health status and whether there have been any adverse events of special interest. I think with respect to lessons learned, it really, it's important to have a strong pharmacovigilance system and rely on one another. In other words, there's oftentimes quite useful information coming from other countries that can identify possible safety signals as well as reassurance on safety. But in addition to that, it's working alongside of your EPI or your immunization programs so that there is this connection between the regulators and the public health agencies in order to share information. And then thirdly, I would say there's a phenomenon whereby there are what are called HDSS sites that are throughout Africa, and including in Kenya, whereby there's enumeration of health events in a defined community. That's supported through active surveillance. And that's a good example of a platform for epidemiology that could be leveraged in order to be able to do this kind of work on active safety surveillance during pregnancy. And the last thing I'll say is as vaccine developers continue to be a phenomenon in various parts of emerging economies or elsewhere in the world, I think it's also incumbent to ensure that they have strong safety units within them, and that this is a responsibility for monitoring safety of product that is a shared one. not only within the government donors, but also with the market authorization holders. So, rely on your academics, your government, the market authorization. It takes a village to do this kind of work, but there's lots of examples out there, including in Africa. Thank you.
Right, thank you very much.
Yeah, thank you.
Thanks, Andy. Unfortunately, we have to close. There's a couple of hands still, but I've been warned to stop right now. So, without much ado, I'd really like to thank the guests, Professor Andy, Professor Meyer, Dr. Raberra, for coming through and sharing the insights on working towards a healthy Africa, evidence for strengthening programs. I'm going to share your contact information with some of the guests who would like to ask questions, if you don't mind.
My name is Dr. Prashant Mandaliya. My supervisors are Professor Faith Okolebo, Professor Edwin Barasa, and Dr. Dorothy Iwak. And I think Professor Okolebo and Dr. Iwak are in this room, so I'd like to thank them for being here. So I'll start with a brief introduction. So in 2018, 5,985 new cases of breast cancer were reported in Kenya. Between 20 to 30% of these cases were HER2 positive. HER2 stands for Human Epidermal Growth Factor Receptor 2. And this form of breast cancer is more aggressive. A monoclonal antibody by the name of TRASTUZUMAB is recommended for its treatment. However, at the time, NHIF only covered 4 cycles per year of TRASTUZUMAB with a maximum payout of 150,000 Kenya shillings per cycle. So a majority of the patients will either have to pay out of pocket once their NHIF is exhausted or defer their treatment till the following financial year. And generally, because of its high cost, most patients couldn't afford paying out of pocket, leading to poor treatment outcomes. So our research questions are, what are the direct costs of trastuzumab-based treatment? Which trastuzumab-based regimen is the most cost-effective and affordable? And what would be the impact of fully funding these trastuzumab-based regimens on the NHIF budget? So we look at the comparative interventions of the trastuzumab-based regimens I was talking about. I'll draw your attention first to the 9-week regimen because it's a bit unique compared to the rest. So the 9-week regimen has 3 cycles of paclitaxel, followed by 3 cycles of fluorouracil, epirubicin, and cyclophosphamide, followed by 3 cycles of trastuzumab. Then we have the reference group, which is without trastuzumab. That's just chemotherapy on its own. That's 4 cycles of doxorubicin with cyclophosphamide and 4 cycles of paclitaxel. And then the remaining trastuzumab-based regimens are very similar to the reference group, only that trastuzumab is now added with the paclitaxel for the 4 cycles, and then it's given on its own for varying durations depending on the duration of the regimen. The methodology was divided into 3 parts. First was a cost analysis. This was followed by a cost-utility analysis, and then finally a budget impact analysis. So the study design is a cross-sectional survey with a Markov model. The time horizon was 5 years with a 1-month cycle length. The costing approach was a micro-ingredient approach from the payer's perspective. The sensitivity analysis was a one-way and probabilistic sensitivity analysis, and data was collected from face-to-face interviews, market survey, and literature. So we'll look at the Markov model. So it has the various health states. Patients would start at diagnosis and treatment, and then move to disease-free survival. And then from here, they can move to the various health states based on the transition probability. So each arrow has its own transition probability, and each health state has a utility value and a cost attached to it. So I'll move on to the results. So the results are presented in the form of an ICER, that's the incremental cost effectiveness ratio, which is in Kenya shillings per quality adjusted life year gained. As you can see, the 9-week regimen had the lowest ICER at just over 5.5 million Kenya shillings per quality adjusted life year gained. The 6-month regimen had the highest ICER at just above 7.1 million Kenya shillings per quality gain, and the remaining trastuzumab-based regimens had an ISA ranging between 6.6 to 6.9 million Kenya shillings per quality gained. Next, I'll draw your attention to the cost-effectiveness acceptability curve. So what this shows is, with different willingness to pay thresholds, which regimen would have the highest probability of being accepted. So from literature, we found that the willingness to pay threshold for Kenya was approximately $919 US, and with the exchange rate of the time, that equated to 111,000 Kenya shillings. So with that value, we can see there is a 100% probability that chemotherapy only would be the most acceptable regimen. But if we increase the willingness to pay to above 6 million, we can now see trastuzumab-based regimens such as the 9-week regimen has a higher probability than chemotherapy on its own to be accepted. And above this, the 24-month regimen had the highest probability. Next, we'll move to the results of the sensitivity analysis. So this is a tornado diagram, and it shows which parameters were most sensitive to the ISA. So from our study, we can see the quantity, I hope you guys can see it clearly, is the quantity of trastuzumab was the most sensitive parameter. Other parameters which were sensitive were the risk of dying by breast cancer, and also the utility values for the different health states. This was the results of the budget impact analysis. So we estimated over the 5-year period in Kenya, 6,100 patients would require treatment for HER2, positive breast cancer. And roughly, if I draw your attention, again, because it's the cheapest trastuzumab-based regimen, the 9-week regimen would cost just under 4.2 billion Kenya shillings for Kenya over the 5-year period for all 6,100 estimated patients. And we forecasted the NHIF budget for 5 years by using the 2020 budget and then increasing it by 15% every year to cater for inflation. So approximately 1.4% of the NHIF budget would be needed to be catering for these patients in the 9-week regimen. The discussion, so as I said earlier, the 9-week group had the lowest ISA, but with the current willingness to pay, none of the trastuzumab-based regimens would be acceptable in the Kenyan context. But all the trastuzumab-based regimens were more effective than chemotherapy on its own, which was the reference group. So this is just a comparison of our findings with that found in literature. So the 5-year overall survival was 83% in our study, while that found in literature was at about 88.6%. The 5-year disease-free survival was just under 80%, while that found in literature was about 84%, while the median 5-year cost for, again, 12-month regimen of trastuzumab was 1.78 million Kenya shillings, while another study also done at Kenyatta National Hospital using a different costing approach got a value of 1.7 million shillings. So there were similarities between our findings and that from literature. So in conclusion, I would like to say regimens with trastuzumab should not be dismissed simply because of a low willingness to pay. Instead, we should look for interventions to reduce the cost of treatment and also improve health outcomes, because this in turn would help reduce the ISA. And generally, fully funding these treatments lead to better health outcomes and a form of cost savings as well. And cost savings in the sense because when there are better treatment outcomes, there'll be less incidences of local recurrence, metastasis, hospitalization of the patients, and also better quality of life for these patients, making them more useful members of society. So these were our recommendations. To reduce costs, we would recommend good dispensing practices and vial sharing where appropriate, direct procurement from manufacturers and the use of generics or biosimilars. And in terms of improving health outcomes, screening, early treatment initiation, and patient counseling was our recommendation. So I'll end my presentation with a quote by Orieko et al. The selection of suboptimal therapy is a reality in many African countries, whereby patients break down emotionally when informed about trastuzumab based regimens. So these are my references. Thank you, asante sana.
My name is Dr. Njeri Estamburu. I prefer using my local language. That's why the Esther is in me. I'm excited and delighted to be here with you to speak about something that is very passionate to me. And Miles has said that we use the shortest time possible. Oh, so help me God. You know, when you're passionate about something, you want to go on, but I will try my best to be as fast as possible. So I will talk to you about a baby that we have conceived for like 3 years. We've been bearing it for 3 years, and it's time for us to bring it to people for you to consume what you're doing, and it's called CONSULT-IS. So I tend to internalize health system as a funnel. So you find a hospital or health system network or the environment, it's the top part of the funnel, and the pharmacy is very critical because it's one of the things without having in a funnel, you can't channel information. And during the entire conference time, we've been saying we are just not pushers of commodities. We are also service providers, right? So with that knowledge, help me walk this journey. I will try my best to go less than 10 minutes, I promise. So you find, normally when we are managing patients with NCD, call it diabetes, call it hypertension or whatever, you find we tell our patients, please come back after a certain period of time. And within this period of time, call it a month, 3 months, 6 months, a whole year, depending on the severity of the patient's case, you find they go home. And when they're at home, that period you don't know what's going on in their lives. You may find a patient who is hypoglycemic at home, but they didn't know and you didn't capture. Or they come to the hospital when they are too sick. So this is the kind of challenges that we are facing currently in the health system, especially the hospital setup, where you find by the time our clients or our patients come back, either they are worse or they are at a position you could have intervened. Sometimes you are like, I wish I caught this early. So, or rather, for diabetes case and hypertension, we rely on, I hope they went home, they took their glucose reading, and they come to the hospital with notebooks that they wrote their readings. Other than that, you are left wondering, did they really take their medicine? Did they do things that are needed? So you find when they go home and they take their BP or their glucose levels, they find values, right? For us, values make sense. A 1 is not a 1 in a glucometer. It means someone is seriously hypoglycemic, right? But for a patient, then they just, as much as we educate them, with time you find they go home and they find a value 14 or even 17. And they come for clinic and tell you, my readings have been 17. And you're just like, how did you just walk to the hospital? You should actually be in the ward, you know? So CONSULT-IS is a platform that provides that link between the hospital and the patient. It's a website and application where if a patient inputs their home reading, it stops becoming paper-based and it's online and it translates to the hospital. We are able to see real-time data once they have uploaded in the facility, and even it helps us decongest the facilities. If someone has been having very stable readings, we just tell them kindly, continue refilling your medicine. If you find there's a challenge, even before their return date, we intervene on time. So this is the application image. I just took a bit of the screenshots. For instance, at the middle section, you find we even ask them to take data of before bedtime. This helps us to go further in our management for diabetic patients and capture the moments of if the person actually is experiencing Down syndrome. It's no longer just hyperglycemia or diabetes. We go to the nitty-gritties once we have this data. The below section is the one for the website. Now the bulk of it that is run by the facility or the hospital. For us pharmacy, we have introduced the MTM facet of it, apart from the commodity aspect of it. So that once you're having that one-on-one conversation with the patient, you are able to capture everything needed for them so that when they come for another MTM clinic, you have the previous data and what you discussed about that. I will just allow you to scan through that. That is some of the advantages. I know when you are I was discussing, there are some bulbs that are lighting up in your head, and you could be able to relate to the fact that now we are integrating the care of our patients with even other healthcare providers. So when they come to pharmacy, we do MTM, we give them medicine. We are able to even see the previous prescription they had, what went on, what conversation they had with their clinicians, so that we just don't manage our patients in exclusion. We treat them in totality and in understanding of what they are going through. And of course, data, we will be able to generate data because now we are able to have a whole database and can do a lot of studies, not haphazardly or helter-skelter when we are doing that. In conclusion, as I promised, hope I've kept my time, Miles. Values stop becoming values to our patients if we pharmacists intervene. Because we have been very endowed with knowledge, we know the clinical aspect, and we are grateful that patients so far have been putting a lot of trust in us. So we are able to relay that message to them, and that makes us the metadata. If you have data without metadata, it just becomes useless. So we are able to break down things, and patients can reach out when they're at home, and we can be able to intervene on time. I can't boast I did this whole thing alone. I've been privileged to be with a team of wonderful people, different cadres. We have Matthew, he's our ICT expert. I am with Professor Opanga. And then we have these two wonderful people beneath. They are students. We are mentoring them into innovation world to bring health. Because we strongly believe in consult is, once we marry health with IT, we can be able not to bring challenge with IT to health, but to marry health with what we already have in existence. So thank you very much.
I'm Dr. Florah wetende from KILIFI County Hospital, and my abstract was on promoting prescription etiquette towards rationalizing antimicrobial stewardship using the COMB model. Okay. So justification for this, we all know antimicrobial stewardship, antimicrobial resistance has been on the rise, and there are projections that by 2050, deaths related to antimicrobial resistance will surpass those related to cancers and lifestyle diseases essentially. So this is a threat to public health, and there's need to curb antimicrobial resistance. So among the interventions we chose as pharmacists was to promote prescription etiquettes. So what is antimicrobial prescription etiquette? Actually, it's guidelines, unwritten rules and guidelines that influence how prescribers choose and use antimicrobials. And the core principles of prescription etiquette involve use of evidence-based guidelines to choose antimicrobials, use of narrow-spectrum antibiotics, using an optimal dose of an antimicrobial agent for the shortest duration of time, and prescribing these drugs only when necessary. So what is COMB? It is a framework, an acronym for C stands for capability, opportunity, and motivation. These are all factors that need to be present in order for behavior to occur. And so if at all you need to change a behavior, then you'll have to look at all these factors for behavior change to be effective. So the objective of this was to implement the COMB model towards improving prescription, antimicrobial prescription, and also to conduct a prescription etiquette audit to know where we are as a facility. So this study is an interventional type of design, and it was done in 3 phases. Phase 1 was to gauge knowledge and access enhanced capabilities of our prescribers. Phase 2 was to address any opportunities present, and phase 3 was to promote motivation. So in gauging knowledge and enhancing capability, we did this through pre-CME surveys, post-CME surveys to gauge the knowledge. And also, in order to enhance capability, then we conducted CMEs, training the clinicians and prescribers on what antimicrobial resistance is, appropriate antimicrobial prescribing, and all that. In addressing opportunities, we majorly increased the physical opportunity, which entailed provision of resources, like availing guidelines through our mobile app, the prescribing companion app. Also, we have an active antimicrobial stewardship committee, which offered a consultation. Some of the barriers were identified throughout this whole process, and in addressing opportunity, we addressed the barriers too. In promoting motivation, we conducted the prescription audits together with departmental feedback, and this feedback, we had to recognize champions and give them incentives. Yeah, that's some of the work we did. Okay, on to the results. Enhancing capability via improving knowledge. This is just a sample of the pre-CME that we did, both pre and post-CME. Clearly, there was an improvement in knowledge, both on the local resistant patterns for Kilifi County, diagnostic stewardship also, the knowledge improved. The need to do evidence-based prescribing via blood culture and sensitivity, and also enhancing knowledge on where clinicians could get resources for antimicrobial stewardship and prescribing. Motivation and feedback. A cross-sectional survey was done with over a week late last year. A total of 720 prescriptions were analyzed, and we majorly focused on prescription quality. Prescriptions being prescribed in generic were at 82%. Prescription with appropriate dosage and frequencies of antimicrobials were 99%. All 20% of these prescriptions had the weight recorded. 99% of the prescriptions had age indicated to facilitate age-based and weight-based administration of drugs. 74% of the prescriptions were legible because they are still paper-based. 43% of all these prescriptions in the outpatients over that week contained at least an antibiotic. So on key prescribing indicators, we looked at the number of antimicrobials having injectables, combination antibiotics, that is 2 or 3 or more antibiotics, number of drugs, antibiotics from the essential medicine list, the Kenyan one, average medicines per prescription, and the percentage of antibiotics from the access group against the WHO standards. So clearly, we were doing well, especially with the average medicine per prescription, we were at 1.9%. Then percentage of antibiotics from the access group, we were doing a bit okay, 83%. And that is after we did an aware categorization dispensing policy for antimicrobials at our outpatients. Yes. That is part of the feedback and recognitions of healthcare workers. So on to discussion. This model identified barriers to this intervention. Some of the barriers were the heavy workload, especially at our public facility, and resource constraints. We had erratic supplies of both antibiotics and standardized prescription pads. Limitations to this study is that the audit was just done over a week. It's a snapshot, so it can't really represent, we can't conclusively base our conclusion on that. So future research could explore the impact of this intervention on antibiotic resistant rates, the sustainability of this intervention, cost effectiveness of an analysis of this intervention. We might compare the cost of access category of antibiotics as to those of reserved, and broader applicability of these models to target other areas of AMS and medication management, especially for pharmacies. So in conclusion, the COMB framework really offered powerful framework for improvement of antibiotic prescription. Also knowledge among healthcare workers improved, and it increased access to antimicrobial stewardship and diagnostic stewardship resources. Repeat audits will be needed to evaluate the effectiveness of this model. Yes, those were some of my references. Acknowledgements, I didn't do this work alone. I have a whole team with me. The clinical pharmacist, Dr. Elizabeth Gadua, right there. Dr. Agrippina Masha, Dr. Shahada Mevin, and B. Young, and the rest are not currently present. Thank you.
Good afternoon, my fellow delegates, ESK Organizing Committee, International Society Pharmacoepidemiology officials, all protocol observed. My oral presentation is the comparative in vitro quality assessment of telmisartan 40 mg INNOVATOR versus the branded tablets commercially available in community pharmacies in Parklands and ROYSAMBU area. A generic drug is that in terms of its active ingredients, dosage form, potency, mode of administration, quality and intended use is equivalent of a brand name drug. Generic drugs are approved by the regulatory authorities such as the Pharmacy and Poisons Board. The global market size of telmisartan is valued at $3,453 million in 2019 and is projected to reach $4,258 million by 2027, registering a compound annual growth rate of 3.4% from 2020 to 2027. It is a cardiovascular drug prescribed in the management of hypertension, heart failure, to prevent strokes and heart attacks. Recent evidence shows that telmisartan provides renal benefit at all stages of renal issues in patients with type 2 DM. The Quality Control Department ensures that all manufactured drugs meet established specifications for identity, strength, purity, and other characteristics. Aim of the study: general objectives to carry out the quality control tests of different telmisartan brands in the Kenyan market. Specific objectives: to identify the 4 generics in the Kenyan market by carrying out a survey, to assess the non-pharmacopoeial tests on the generic telmisartan and Micardis, such as the appearance, weight variation, thickness, and hardness, to evaluate the pharmacopoeial tests of telmisartan, such as friability, disintegration, and dissolution, to perform an assay of telmisartan tablets and the 4 generics performed using the UV spectrophotometer. All tests were performed in 3 trials, 10 tablets of each according to the BP. From 35 pharmacies surveyed in Parklands and ROYSAMBU area, we found that over 10 brands of telmisartan 40 mg and more than 50% of the pharmacists did agree that generic medicines are as effective as branded. 75% of pharmacists would replace generic drugs with the branded medications. Price difference between generic and branded is about 80%. Generic drugs are considered to be of lower quality than the name innovator medications. There is a delusion that generic medications do not work in the same way as the innovator drug medication. There is an increase in the cost of the healthcare as innovator drug medications are approximately 2 to 3 times more costly than the generic brands. Therefore, there is an emphasizing need for thorough quality and safety assessment for the pharmaceutical generic products to achieve their objectives. The general appearance test of the sample tablets from the 5 brands showed that all of them had uniform color distribution, were undamaged and odorless. All brands and packaging and labeling comply with the BPE specifications. The thickness test of a tablet is a critical parameter measured using a vernier caliper in the pharmaceutical formulation and manufacturing, influencing dosage, uniformity, drug release, patient compliance, manufacturing efficiency, stability, and safety. The ability of tablets to tolerate mechanical shocks from handling during manufacture, packaging, and breakage during transit is evaluated using the hardness. The right amount of tablet hardness is about 8 to 16 kgs. Therefore, only TEL1 complied with the criteria. The rest of the 4 samples did not comply with the acceptance criteria. All samples from the 4 brands conform to the BP standards. TEL1 had the least percent friability by the friability test, and this suggests that more force was used to compress the tablet during production as opposed to the other brands. All brands passed the weight variation test, and TEL3 had the highest weight variation, and that means it had the flowability of a powder blend better than that of the other brands.